All right, Lauren, I think we can go ahead and get started and we'll just keep letting folks in just because I know we have a lot to put in to tonight's presentations. So we want to use every minute.
Sounds good.
Okay.
All right. Here we go. Here's our agenda for this evening. Celia, did you want to share this?
Yeah. So
Okay, thank
welcome
you.
everybody. We're really excited to be here. We've actually got two presentations tonight. So we will get moving as soon as we can, but we'll begin with our welcomes and our introductions, and I'll do that in just a minute. And then we'll start with Dr. Black. And then we'll take some time for questions and answers. Please know if you have questions for clarification to understand as either of the speakers are speaking, please put those in the chat and we'll address them as we're going. And then we'll have time for Q&A afterwards that are more about what you heard and how you might apply it to you or your family situation. So if you'll keep that in mind, and again, put your questions about clarification in the chat, but larger questions for later on. And we'll stop for question and answers after Dr. Black is finished. And then we'll move forward with Dr. Patel. And again, follow up with questions and answers, and we'll wrap up. And then we'll always remind you to please do your evaluation. Part of your evaluation will be letting us know whether you want a link. Dr. Black and Dr. Patel have agreed to record. So we hope to give you a link to that. Now, I say that out loud, but we did not get a chance to talk. Dr. Patel, I want to make sure you wave to me, and are you okay with recording? If not, we always let that be determined by our presenters. Okay, great. So we've got the thumbs up on that. So if you want a copy of that recording, please let us know when you complete that evaluation. So very briefly, I think folks are getting to know us, but we are the RTS OKI team that sits at Cincinnati Children's Hospital. Dr. Ilka Riddle is here. She can wave. She is our astute director. And we are coming from the University Center for Excellence in Developmental Disability that sits within our Children's Hospital Division for Developmental and Behavioral Pediatrics. In addition to myself, Celia Schlomer, who does family support and supports the Ohio, Kentucky, Indiana, Rubinstein-Tabby syndrome family support group, is Lauren. Lauren, why don't you introduce yourself real quick?
It's really nice to meet you all. My name is Lauren Bird. I've been in this position for about 6 months, and I'm supporting the speaker series and some in-person events that we're hoping to reinvigorate for 2025.
And Lauren is a very welcomed part to the team in that we definitely are busy folks with these opportunities. And so I'm really tickled to have her, and I'm going to formally thank her in front of the hundreds of folks that are registered in here because I really appreciate Lauren brings a great deal of insight and ideas to this group and keeps me energized. So I appreciate that. So, well, we're going to go
Thank
ahead.
you.
Yeah, and get started. I want to begin by introducing Dr. Catherine Black, and she's an assistant professor of anesthesiology at the University of Cincinnati and practicing anesthesiologist at Cincinnati Children's Hospital. And Dr. Black has a particular focus on patient safety and anesthetic management for medically complex kiddos. And her research interests include studying anesthetic considerations and risks for children and young adults with rare genetic disorders. And that's how we've come to know her. And we're really excited about what she's got to share. So I thank you. And I'm going to very quickly turn over the mic to Dr. Black.
Hello, thank you so much for having me. I'm going to share my screen quickly. Can you see everything?
We can. Thank you.
Present.
We are not seeing presenter view yet there. There we go.
Okay.
Perfect. Thank you.
Okay, thank you all for being here. Very excited to talk with you all. My name is Catherine Black. I'm an anesthesiologist at Cincinnati Children's Hospital, as you heard. I did my training in anesthesia at University of Virginia and completed my fellowship in pediatric anesthesia at Boston Children's Hospital. And I'm really excited to talk with you about anesthetic considerations for patients with Rubinstein-Tabby syndrome. All right. So, little summary of what I'll talk about. So first, I'll talk about what I'll talk about. So first, I'll talk about what is anesthesia in general, what anesthesiologists do, and what are some anesthetic risks, in particular for patients with Rubinstein-Tybee syndrome. So to start off, what is anesthesia? So anesthesiologists use medications to place patients in a state of consciousness to allow them to undergo a procedure. We know that anesthesia is a spectrum. On one end, we have the awake patient who's able to form memories. They're able to respond normally to pain, touch, and to sound. They are breathing on their own. And as you can tell of this young child, probably not appropriate to undergo many procedures under this state of consciousness. Procedures that are appropriate under this state of consciousness would be adult dental cleaning, skin biopsies with numbing medicine, but not much for children. The next state that we can, as anesthesiologists, place people in is minimal sedation. For this, we give medicines for anxiety and to keep patients calm. In this state, patients are unable to form memory, or they are able to form memories. They do remember and are aware of what's going on. They're able to respond normally to pain, to touch, and to sound, and they are able to breathe on their own. Procedures that are appropriate for this are non-painful procedures such as dental cleanings or echoes. This can be things where maybe children are a little bit nervous about the procedure, but it's not painful. So they're able to get through it with a little bit of medicine for anxiety. Deep sedation is next. As you can see, this patient is asleep. They're not aware of what's going on. They're not forming memories, so they will not remember the procedure. They do not respond to touch or to sound. However, they do feel and respond to pain sensation. And as you can see, they may need help with breathing. Things that are appropriate for deep sedation are things that are not painful, but you would not necessarily want to be awake for, such as colonoscopies or endoscopies. And then on the final end of the spectrum, we have patients under general anesthesia. So under general anesthesia, patients are not forming memories. They're not aware of what's going on. They do not respond to pain, to sound, or to touch. And they will likely need assistance with breathing, and they will need a breathing device. As you can see, this patient has a breathing tube and they are hooked up to a ventilator. And sometimes patients will need assistance to keep their blood pressure in a safe range to counteract the medicine we give with anesthesia to keep them asleep. Procedures that are appropriate for general anesthesia are painful procedures such as appendectomy, scoliosis surgery, or detethering surgery that we'll hear about next. So what do anesthesiologists actually do? First of all, they need to understand the patient, the specific risks that they have for anesthesia and the procedure being performed, and the surgical needs. This involves reviewing the patient's medical history, looking at previous anesthetics, looking at their studies, their labs, interviewing the patient and the family, and examining the patient. This also involves talking with the surgeon and what the surgeon expects to do and what the surgeon needs from the anesthesiologist. One thing that you can talk about is how painful the surgery will be. If it's not going to be painful, then perhaps moderate or deep sedation is appropriate. If it will be painful, like detethering surgery, then you need general anesthesia because we don't want the patients to feel that pain, of course. The next thing the anesthesiologist does is optimization. So the point of optimization is to make sure that the patient is in the best shape possible to undergo the stress of surgery and anesthesia, and hopefully avoid dangerous outcomes that could otherwise have been avoided. So what this means is seeing the patient and seeing if if they're sick that day, if they have a GI bug, or if they have a cold. Maybe they're not in their best shape. They're perfect, as perfect as can be health condition to go through a stressful surgery. So that's what optimization looks like. It also means talking with other specialists who are taking care of the patient. For example, that could be an endocrinologist if the patient has diabetes, and talking with them about their specific recommendations for getting the patient through the surgery. That could mean what blood sugars should we proceed? What blood sugars should we stop? What should we do with their diabetes medications before, during, and after surgery? Things like that. This is also a time where if you see the patient and I'm concerned that maybe they have something that they're not optimized for, such as if you see them and maybe they're wheezing, their oxygen levels are low, that could mean that would be a time potentially to refer them to a pulmonologist to be evaluated and see if they need further medications or studies before undergoing a stressful surgery. This is also a time when we consider getting further labs or studies and potentially bundling procedures. A lot of the surgeons are very helpful with this as well. If a patient needs ear tubes and a gastric feeding tube, perhaps it's best to bundle the surgeries so they can avoid further and multiple anesthetics and surgeries. The next thing that an anesthesiologist does is come up with a plan. What is the safest anesthetic possible for this patient? We weigh the potential risks and benefits of a specific approach and determine the best path forward. We also, at this point, make contingency plans. If our first plan doesn't work, what are we going to do to try to get this patient through this surgery and anesthetic safely? And then we also discuss and decide the appropriate post-op placement. And this is done with the surgeon as well. Are they appropriate to go home after this surgery and anesthetic? Do they need to be watched on the floor and admitted to the hospital? And potentially, do they need to go to the ICU where they can be watched very closely and make sure that they're safe after that surgery? So that's all the things we talk about at that time. And then, of course, we discuss the risks and the benefits with the surgical team and family. And then we enact the anesthetic plan that we spent all that time coming up with and working on. And then when the surgery is finished, if the patient is not going to the ICU, they go to an area called the post-operative care unit, or the PACU, or the post-anesthetic care unit. And there, the anesthesiologist is in charge of making sure they recover safely from anesthesia. So we're responsible for taking care of them there as well. So why are patients with Rubinstein-Tybee syndrome high risk for anesthesia? So to answer this question, we'll go through all of the characteristic features of patients with Rubinstein-Tybee syndrome, and then we'll pick out certain features that have implications for their anesthetic care. So typical facial features, many of us know this. So arched palate, large tongue, small chin and mouth, small head, downward slanting eyes, raised nasal bridge, arched eyebrows, small upper lip, potential tooth abnormalities as well. So of course, not all patients have this, but it's possible that some of these features could result in the patient having what's called a difficult airway. To have a difficult airway, that means one of two things. Either one, they're difficult to mask ventilate, and we'll talk about that in a second, and or two, they're difficult to place a breathing tube. And patients with Rubinstein-Tybee syndrome are known to be difficult, to have difficult airways. So what is mask ventilation? So as you can see here, this is an anesthesia mask, and this mask is placed over the patient's nose and mouth, and this bag is squeezed to deliver a breath to the patient when they are unable to breathe on their own. This can be challenging if the patient has a small chin, as many patients with Rubinstein-Tybee syndrome have, or if they have a large tongue, which many of our patients do have. This can also be challenging if the patient has a large beard as well. So these are some devices that we can use if mask ventilation is challenging. This is called an oral airway. There's a hole that runs through this plastic device right here, and it fits inside the mouth and lifts the tongue out of the way to create an opening so that air can be delivered to the lungs and the patient can breathe. This is another device called a nasopharyngeal airway. As you can see, similarly, it's placed in the nose and moves some of the tissue out of the way and allows us to ventilate the patient. So being a difficult mask means that it's challenging or impossible to breathe for the patient using a mask when they're unable to do so for themselves. And patients with Rubinstein-Tybee syndrome are known to be difficult masks because of the characteristic large tongue and small chin. So we talked about difficult intubation. That's another thing that Rubinstein-Tybee syndrome patients are known to potentially have. So what does that mean? That means it's difficult or impossible to place a breathing tube. This is a breathing tube. As you can see, it's a tube and it has this little balloon at the end. It's placed into the mouth here, down back behind the tongue, past the vocal cords and into the windpipe or the trachea. There's a little balloon that is blown up here that protects the lungs from anything going down there that shouldn't, and it also keeps the breathing tube in place. This is a view of what we hope the airway looks like when we're placing a breathing tube. You can see that here, these are the vocal cords, and they are on either side of the windpipe, also known as the trachea right here. And ideally, the breathing tube would come right down here and go into the trachea. However, it doesn't always look like that, especially in patients who are difficult to intubate. We hope that it looks like this, like we talked about, clear open path of where we place the breathing tube. But sometimes it looks like this, where you can only see part of the opening, or sometimes this, where you can't see it at all, and maybe you think it's under there. Or sometimes it looks like this and you can't see anything that you know what it is. So what do we do when that happens? This would be potentially a difficult intubation. So these are some of the devices we use to place breathing tubes. This is called a laryngoscope. This is called the handle, and this is the blade. On this, there's a little light deck here, and as you can see here, it's placed in the mouth, moves the tongue out of the way, lifts up all these tissues so that we can see this, hopefully, this view here and place the breathing tube. But if there's a lot of things in the way, if it's a difficult view like this or even this, then we can use other devices to place a breathing tube. This is a video laryngoscope. This device right here is just similar to this. However, there's a little camera at the end right here. And this blade here is a little bit more hyperangulated. So it's able to look around soft tissue and see things that we wouldn't be able to see with the naked eye. And there's a little camera and a screen here that you're able to see and place the breathing tube through. This is another device that we can use. It's called the flexible fiber optic. And this is a flexible little tube that we can use to carefully go down into the mouth and place it into the airway. So how do we predict a difficult airway? So there's a couple of different scoring systems and things that we do when we're examining a patient to try to predict if they may be challenging to intubate or to mask ventilate. Here are some of the exam maneuvers that we do to try to predict a difficult intubation. This is called a Malampati score. So you can ask the patient to open their mouth and stick out their tongue, and based on how much you can see beyond their tongue, predicts if they will be potentially a difficult intubation. So this one where you can see the uvula and the palate behind, that's a good sign that they'll potentially be easy or not difficult to intubate. But this one where you can't see anything back behind the tongue is a little bit of a warning sign that they may be challenging to intubate. And especially if you have a big tongue or small mouth opening, like many children with Rubinstein-Tybee syndrome, that is certainly a sign that they may be challenging. You also, there's also a scoring system for neck movement. If you have limited neck movement, that's a potential concern that you're difficult to intubate. This is another maneuver you can do to see how far you can move your chin. If you can take your bottom teeth and bite your top lip like that, then that is, that's good. That means that you may be easier to intubate, but if you cannot, then that means that that's another warning sign that it could potentially be challenging. And then there's the mouth opening as well. If it's a small mouth opening, like patients with Rubinstein-Tybee syndrome, this is another indicator they may be challenging. And then, of course, chin size is also predictive of how easy it is to intubate. So here are a few other airways that we can use for patients with anesthesia for under general anesthesia that you may have heard about. So this is a laryngeal mask airway. It's similar to a breathing tube. However, at the end, instead of a tube that goes past the vocal cords and into the windpipe or the trachea, there's instead of this little balloon and opening that sits just at the opening of the trachea and doesn't go beyond the vocal cords. So it's a little less invasive. However, there are downsides to using this. With the breathing tube, it goes all the way into the trachea and a little balloon blows up here down above the lungs. And that's with the breathing tube, that's nice because it protects the lungs from anything going up and down into the lungs. The LMA, the laryngeal mask airway, does not protect anything going down there. So if the patient were to have things come up from their stomach, there would be nothing protecting the lungs, and the patient could potentially aspirate, which we'll talk about a little bit more in a moment. And then another airway we can use is a surgical airway, also known as a tracheostomy. So this is a surgically placed tube at the front of the neck. And this can be used for anesthesia if the patient already has it. So now we'll go through some of the other features of Rubinstein-Tybee syndrome. So some of the GI symptoms. So characteristically, many of these patients can have feeding difficulties. They can have aspiration or a lot of acid reflux. Many of these patients suffer from constipation as well. So the thing that we are really concerned about with the anesthesia with these patients of all these three factors is their aspiration risk. So when someone aspirates, that's this acidic fluid in the stomach that goes up into the lungs and causes problems. If this acidic fluid goes into the lungs, as you can see it has here in this chest x-ray, that can damage the lungs and prevent them from functioning properly. If that happens, that means the patient is unable to absorb oxygen, unable to release CO2, and they essentially cannot breathe if it's a large part of the lungs that has been affected by this aspiration, this gastric fluid from the stomach. So when does this happen? When is the patient at highest risk for this happening during anesthesia? So the highest risk time is immediately after the patient is placed under general anesthesia. When we are awake, we're able to protect our airway. So that means we have reflexes to cough and to close our vocal cords when fluid touches our airway. So many people may experience this. If you're drinking and fluid goes down the wrong pipe, you'll immediately cough, your vocal cords will close, and you'll have that protective reflex that's protecting your body from aspiration. However, under general anesthesia, you lose that protective reflex, and any acidic stomach fluid can freely flow down into the lungs if it's not protected by a breathing tube. So how do we prevent this from happening? The typical way is to place the breathing tube as quickly as possible and inflate that protective balloon as soon as the patient goes under general anesthesia. We also talk with the family and the patient about how often they experience acid reflux. If they have such severe acid reflux that every time they lay flat, they feel food coming up, then that means they're extremely high risk for aspiration under anesthesia. That's why we have patients not eat or drink for several hours before anesthesia. In extreme cases, we can empty the stomach before going off to sleep, though that's not a pleasant thing to do or experience. Sometimes we can give medications to make the fluid in the stomach less acidic and a little bit more less caustic to the lungs if the patient were to aspirate. And then at the end of the surgery, if we're concerned about aspiration, you can wake the patient all the way up and until they get that protective reflex back before you take the breathing tube out to make sure they don't aspirate at the end of surgery. If aspiration happens, some of the treatments it's typically just what's called supportive care. That means potentially leaving the breathing tube in after surgery, going to the ICU and giving the patient time to recover and their lungs to recover on their own. If it's very severe, we can also suction the fluid out. So that's one. So that is a significant risk for these patients. And we talked about some of the ways to try to prevent it. So moving on, some of the other features of Rubinstein-Tybee syndrome, some of the neuromusculoskeletal features. So these patients may have developmental delay, they may have intellectual disability, potentially low muscle tone, scoliosis. We all know about the broad thumbs, big toes. Hypermobile joints, so more flexible joints than normal. They may have osteoporosis, that means more fragile bones. They, of course, may have brain and spinal cord abnormalities, and they may have short stature. So the things that we worry about with the anesthesia, is the fracture risk. So we know that patients with Rubinstein-Tybee syndrome may have more fragile teeth. Anytime we're placing a breathing tube or anything in the mouth, there's a risk that these teeth may become fractured, or if they're already loose, they may become dislodged and go somewhere they're not supposed to, such as down in the lungs, which would be worst case scenario. And of course, there's a risk of bone fractures as well. So this is some of the positions that we have to place patients in while they're under anesthesia to facilitate the surgery that's being done. So as you can see, lots of different positions, very challenging to place these patients in these positions when they're completely anesthetized. And during these times, if there is a risk, though we're very careful, but there is a risk that patients could become hurt, could have fractures. So that's one concern and consideration that is taken when taking care of these patients, and something to be aware of given that significant risk. And then moving on to the heart and the lungs. Some of the features include recurrent respiratory infections. Some patients with Rubinstein-Tybee syndrome may have sleep apnea, which we'll talk about. They may have something called restrictive lung disease, which is where the rib cage is and the chest wall is a little bit stiffer than normal. So patients are unable to take a big, deep breath. That means they're mostly taking shallow breaths, and they're taking more breaths than normal to be able to have an adequate oxygen level. There is an association with heart disease as well. We'll talk about that in a minute. And they may have something called pulmonary hypertension, where the vasculature and so the vessels in the lungs have a higher blood pressure than normal. So why do we care about recurrent respiratory infections? So what that means is that could be colds, coughs, sinus infections, ear infections, stuffy nose. It's hard to predict when a respiratory infection will be a problem under anesthesia. Sometimes it's fine and everything goes great, but sometimes it's not great and patients become very sick under anesthesia. When you have a respiratory infection, everything in the airway and the lungs is more reactive and sensitive than normal. And there are two big reactions that we worry about under anesthesia. They're called bronchospasm and laryngospasm. So when you have a respiratory infection, you're more likely to have these bad reactions. This is a bronchospasm. These are the small airways. There are thousands of them in everyone's lungs. And this is where the lungs do their work of absorbing oxygen and releasing CO2. There's muscles around these small airways, and when a bronchospasm happens, those muscles constrict and make this tube really thin and small. What that looks like in a patient is like a severe asthma attack. They'll be wheezing, they're unable to breathe, they may have low oxygen levels, and it can potentially be life-threatening. We can see there's an increased risk of this happening when patients have respiratory infections and get anesthesia. The other significant reaction we worry about is laryngospasm. You can see that here. We've seen this before. This is the airway. These are the vocal cords, and down here is the trachea or the windpipe. When a laryngospasm is when these muscles of the vocal cords spasm shut and do not open. So over here is the laryngospasm. That means no air is able to get into the lungs, and the patient can't breathe. Of course, both of these are severe, life-threatening reactions and can be very dangerous. And additional to that, in addition to these two reactions, when a patient is sick with a respiratory infection, their lungs in general become more inflamed and irritated under anesthesia, and they just function poorly. So what does all of this mean for recovery after surgery if you have a respiratory infection when you go under anesthesia? It could mean the patient has to go to the ICU postoperatively. It could mean being intubated for longer afterwards, potentially having more difficulty getting the breathing tube out. It could mean recovery from surgery is much more challenging and they don't do as well. Some of the biggest warning signs for bad outcomes for patients who undergo anesthesia with respiratory infections include being really young. They tend to have the highest risk, being actively sick with a fever, having lung involvement where you can hear them wheezing if they're coughing up mucus, or if they have pre-existing lung disease, if the surgery is on the airways, such as taking out tonsils or adenoids, and if you have to place a breathing tube, which can be more irritating to the lungs and the airway in general. So this is a significant concern and risk factor for our patients. So we talked about the association of sleep apnea for patients with Rubinstein-Tybee syndrome. So what is sleep apnea? So you can see here a picture. Normally when people are sleeping, the air goes through the mouth and the nose and goes down into the lungs. For people with obstructive sleep apnea, the tongue and the tissue back behind the tongue collapses down and blocks the normal flow of air into the lungs. So patients with who have sleep apnea and have anesthesia are at higher risk for having obstruction happen afterwards because they're so sleepy from anesthesia. So these patients may need, if they're predisposed, to be watched more closely in the ICU or in the hospital after anesthesia. And then in general, anyone with lung issues does worse from a lung standpoint after anesthesia and being intubated. So I'll just show you a picture that no matter how fancy our ventilators, lungs don't like being on the ventilator and being intubated. So here is a CT scan. These are healthy. This is a healthy patient before intubation. This is one lung. This is the other lung. This is what it normally looks like. When the breathing tube is placed in just a few minutes after in a healthy patient, you can already see changes on their lungs. Back here in the back part of the lungs, these airways have collapsed. So we have small amount of airway collapse. And you can see just after a few minutes that things things are not as good as they were before in terms of a respiratory standpoint for patients who undergo anesthesia. So anyone who has pre-existing lung issues are worse off afterwards than they were before from a breathing standpoint. And that's why we try to make sure, particularly from a respiratory standpoint, they're at their best possible shape on the day of surgery. And then also we talked about how patients with Rubinstein-Tybee syndrome have a higher incidence of having heart issues when they're born. Things like PDA, ASDs, and VSDs, these are holes in the heart that shouldn't be there. And patients with Rubinstein-Tybee syndrome should probably get an echo before getting anesthesia so that we know if those holes are there. So knowing all these risks, how does one plan an anesthetic for a patient with Rubinstein-Tybee syndrome? Every patient is different and has different risks. No two patients with Rubinstein-Tybee syndrome are the same. One may have a more difficult airway, whereas another may have a higher risk for aspiration, and therefore their risks for anesthesia are different, and the anesthesia plan that would work best for them is different. So when taking care of these children, each risk has to be weighed individually when coming up with a plan. So for example, for every patient we take care of, the anesthesiologist and the surgical team need to talk about, are the risks of anesthesia worth the potential, you can't see it there, what surgery we're getting done? Is it the surgery urgent enough to warrant the risks that we're facing for this patient for getting anesthesia? Is the patient optimized enough? Are they at their peak physical state, health-wise, to do as well as they possibly can under anesthesia and surgery. And that has to be weighed against, the urgency of the surgery and when it needs to come. We also have to weigh aspiration and the risk of securing the airway if it's potentially difficult in these patients. Other considerations are, do we need invasive monitors such as an arterial line, central line, to watch these patients more closely? Or is the risk of placing those lines too high to warrant placing them? Other considerations are we concerned about having a tremendous amount of post-operative pain, or are we more worried about giving so many opioids that they won't breathe as well afterwards? Other considerations are, having really good pain control with nerve catheters versus risks of placing those nerve catheters and potential issues and trauma to the nerves and the spinal cord. And then finally, another consideration is, do we take the breathing tube out at the end of the case in the OR, or do we give them time in the ICU to get the breathing tube out more slowly? So in summary, these patients, all of these risks and considerations need to be thought about beforehand. They need to be discussed with the patient, families, and the team members who are taking care of these patients. They have multiple risk factors for anesthesia, and an anesthetic takes careful planning and discussion about the risks and making those risk-benefit decisions. And that's all I wanted to talk with you all about. I think there may be a couple questions. I'll stop sharing and then take a look in the chat.
I love that. That's all. That's all. Oh my gosh. So much information and so thorough. Thank you so much, Dr. Black. The one question that I saw in the chat, and if anybody else has one, you can either raise your hand or put it in the chat, and we'll take as many as we can, but we want to stay on top of time, and then we can take, if there's more time at the end. But if a child's been intubated as a toddler, would we assume they wouldn't be difficult to intubate a few years later, or would it change as they age and grow, 2 years versus 6 years? And has since been diagnosed with sleep apnea in intervening years. So kind of adding new things to the table. What are your thoughts on that?
Yeah, that's a great question. And I was wondering if someone was going to ask that, actually. Is it one of the most helpful things when planning, to intubate a patient who may potentially be challenging, is if they've been intubated before. So it's often very helpful to see what previous anesthesiologists or whoever intubated them to what their experience was, and if it was easy, if it was hard, if they were difficult to mask, things like that. Typically, for the ease, how well you can place the breathing tube, usually for these patients, it stays similar as they get older. So if it was easy when they were young, it's probably going to be easy when they're older, unless they've had a lot of changes. Maybe they gained a lot of weight, things like that. That could potentially change things. But usually for ease of intubation for these patients, if they were easy 2 years ago, that's a good sign. If they were hard 2 years ago, then that's probably a sign that they're going to be difficult again, and you better have a lot of backup plans. In terms of mask ventilation, so that plays more of a role if they have been diagnosed with sleep apnea. That may mean that if years later that they may be more difficult to mask, and they may have more difficulties afterwards in how well they breathe afterwards. So the diagnosis of sleep apnea is certainly concerning, and that would have to, that could change things in terms of how they do afterwards.
Okay. There was another question in the chat. So Sarah, you get an A+ for asking the question she was hoping to be asked. Real quick, another question. Is it common for individuals with Rubinstein-Taybi syndrome to sleep much longer than other patients due to their metabolism, etc.? Our son sleeps for many hours post anesthesia, so a fluid infusion is mandatory post every time he's given anesthesia.
Yes, sometimes these patients will sleep a little bit longer afterwards. A lot of it depends on what medications they got during the surgery, and every patient is different. And if they slept a lot before, they're probably going to sleep a lot again. So I think that they often do sleep a little bit longer afterwards.
What about age? Somebody had asked, her family member is 51. Does age come into play to make the risks higher?
So in terms of age, That's a good question. So in terms of age, often in terms of airway, it doesn't often get worse as patients get older in terms of intubation. It's possible, depending on how the patient has changed and if they gained a lot of weight or things like that, they may be at higher risk of having sleep apnea and an obstruction afterwards. It really does depend more on the patient, but one benefit of them being older is we know more about the patient. Every patient is different, and so we would know more about this particular patient. Presumably, they've had multiple anesthetics in the past. They probably have had multiple echoes. They probably had multiple chest x-rays. So in some ways, you know more about them than maybe a new patient who's very young, who's just been diagnosed, has never been intubated. So it's a little bit of a tough question, but more depends on the patient specifically.
There you go. And then last one I saw, so if anybody sees that I missed a question, put your little yellow or hand up. I'm trying to recall patient or someone attending said, I'm trying to recall reading something about a particular common medication that's given during anesthesia that kids with RTS cannot have. Is there anything like that the parents need to be aware of?
Yes, I was wondering if someone would ask that as well. So we've got a very savvy group here. So one medication that is that whenever I have a patient like this, I talk about it quite a bit with my team to make sure that no one gives it. So the medication is called succinylcholine. So if patients with, and some patients with Rubinstein-Tivy syndrome do have abnormal muscle tone and potentially abnormalities in their spinal cord. So all of that means is that this medication called succinylcholine, if it's given to patients like that, it could result in an excess of potassium released into the bloodstream, and that can cause the patient's heart to stop. And so it is a very big emergency. This medication is given typically when placing a breathing tube. And it is given because it works really quickly, but there's an alternative called rocuronium that can also work just about as quickly. And the reason why some people would give succinylcholine, hopefully in other patients, not these patients, would be if you're very worried about things coming up from the stomach right when you induce anesthesia, like we talked about. So sometimes they're, and sometimes it's also given by EMS. So it's also a medication that can be given in, an emergency situation out in the field. So it would be something that I think that parents and family members should know about. And there are alternatives to that medication. So it doesn't mean that they would have to get it. So there could be safe alternatives, and that's a great question. I had that as a previous slide and then I took it out, but you guys you're too savvy.
They're smart people. They're smart people for sure. I see Ilka has her hand up. What I'm going to ask, because we're going to get close on time, Catherine, is there's a few more questions we didn't get to in the chat. If you would be so kind as Dr. Patel is presenting to answer those in the chat, and they asked you to spell that medication, and then I'm going to give the floor to Dr. Riddle really quick before we move forward to the next speaker. Go ahead, Ilka.
Yeah, I just, you missed a couple of questions from the beginning. So if we are switching over to Dr. Patel presenting, if Dr. Black can just go through the questions and see what we haven't talked about. I think there's a question about scoring for the airways, and then something about a split uvula. So maybe you can just go in and answer those questions.
Perfect.
Okay.
Thank you. Thank you.
I'll spell succinylcholine down at the bottom.
Yeah.
And just so you can see it, because it is kind of difficult to spell. Okay.
That's awesome. Thank you, Dr. Black. That presentation was amazing, super insightful. I have the pleasure of presenting Dr. Patel, a neurosurgeon on our team. She is a board-certified pediatric neurosurgeon and assistant professor of neurosurgery at Cincinnati Children's Hospital Medical Center. She specializes in complex congenital brain and spinal malformations, including spina bifida and tethered spinal cord, as well as neuro-oncology, skull-based surgery, and craniofacial reconstruction. So I'm going to stop sharing my screen. Dr. Patel, we are delighted and really excited to hear from you.
Thank you very much for that introduction. I will share my screen here. Can everyone see that?
We're not seeing your presenter view yet.
Now?
No, nope, not yet. Now we've got your notes
Oh.
view.
We'll try that again.
That's okay. It can be a thing.
Screen 2. How about now?
There we go.
Perfect.
Okay, all right. Thank you very much again, Lauren, for that introduction. As you, the mouthful of words for what we do in neurosurgery. One of the things that I'm very passionate about, as you mentioned, are congenital brain and spinal malformations, and tethered spinal cord certainly fits in that spectrum. And I take care of patients really from in utero to adult patients that have different spinal malformations. So today specifically, we will focus on Rubinstein-Tibby syndrome and its association with tethered spinal cord. So what is tethered spinal cord and what is tethered spinal cord syndrome? Just in its simplest form, tethered cord is really a clinical diagnosis, and it's based on signs and symptoms that reflect neurological deterioration that can be caused by excessive tension on the spinal cord. And I highlight that because that truly is the basic concept of how a tethered cord occurs and why it causes the things that it does. And it is a clinical diagnosis. So tethered cord syndrome is really a clinical diagnosis that's based on how a patient looks, how they're behaving, how they're feeling, and not necessarily what we see on a picture such as in an MRI or an ultrasound. The diagnosis itself is supported by radiographic findings and other testing, but it's not solely based on imaging. So what are the signs and symptoms of tethered cord? The signs and symptoms can be noticed as early as when a child is born. So signs would be considered things that we find on a physical examination or that you physically see. And symptoms would be described as basically complaints that the patient is having. So some of the earliest signs that we see are findings on the skin or on the back of the patient near the buttocks. So we can see a sacral dimple. Not all sacral dimples are pathologic, but sometimes some of them look a little bit different than what you would typically see in a newborn. You can see abnormal gluteal clefts, or essentially known to everyone as the butt crack. They can be duplicated. You can have a very deep gluteal cleft. You can have it deviate off to one side and have asymmetry there. You can see a tuft of hair on the back that's associated with either a abnormal looking gluteal cleft or a dimple, or have something like a hemangioma. Often looks like a little red spot on the patient's back, or even a blue spot. And so just looking at these images here, all the way to the left of the screen is really going to be this is a sacral dimple, but it's quite shallow. You don't really see a huge dip in there, but it is abnormal. It is above the actual true gluteal cleft of the patient, and the anus is below. In the middle here, you can see at the very bottom of this photograph, that's the anus itself, but you see this divot right here, this pit almost. And that is a dimple that is quite deep actually, and it's lined with skin all the way down to its depth. And all the way on the right side of the screen, you can see this tuft of hair right above this bluish looking area, and a sacral dimple there. So some of the early signs that something might be going on underneath within the spinal cord. The other symptoms that patients can present with over time are discomfort in their back. So it can be back pain that can be described as sharp pain. It can be described as dull pain, shock-like pain. It can happen with walking. It can happen at rest. It can happen with increased activity or towards the end of the day. We can also see leg pain in a similar fashion, leg weakness, trouble with walking, so gait disturbances. Often we see one of the classic signs of an abnormal gait in a patient with a tethered cord is this tiptoe walking. And that's typically something that is pretty consistent, and it's usually seen in patients who have already started walking normally, but all of a sudden they start walking up on their toes. And toddlers often toe walk, and that's considered a developmentally sort of normal variant. But when we see patients that are past the ages of 4 or older, toe walking is not supposed to be a normal thing. Patients can be unsteady. So a child that was walking okay before, but all of a sudden starts to become clumsy, or perhaps they just have always been clumsy. We may see orthopedic deformities, so deformities in the feet, in the legs, and that can be as severe as something called a club foot, where the foot is actually out, it can be turned all the way in or all the way out. Or a leg length discrepancy, where the two legs are different lengths and they don't match. We can see scoliosis, so curvature of the spine, or posture changes in patients that develop over time. We can see patients who have been potty trained perhaps already that are now regressing with their urologic function, having accidents, having the inability to start a stream, or even presenting with recurrent urinary tract infections related to bladder dysfunction. I can also see bowel dysfunction. That can take the form of bowel incontinence, which again, they're accidents, or constipation. So really a large spectrum of signs and symptoms that can be associated with tethered cord. So what are the considerations in patients with Rubinstein-Tabi syndrome? So specifically, the estimated incidence of tethered cord in this patient group is about 5% or less. Now, this is really based on a handful of studies because of the rarity of this disorder. And so we don't, as we get more and more literature, and as we get more and more savvy with diagnosing the condition in patients with RTS, I believe that this incidence will change, and it could be less, it could be more. But it really is truly a game of numbers right now, just because of the limited data that we have. We can see a difficulty in diagnosing patients with tethered cord that have RTS. And specifically, I've noted 3 things here that make it extremely difficult, because patients have some baseline level of intellectual disability. It can be difficult for them to express that they are having pain or discomfort or having trouble. There are a whole host of other anomalies that are associated with this syndrome. And so are those separate, or are those a part of a tethered cord syndrome picture? Patients can have tethered cord, but have not reached the age of toilet training yet. And so what does that mean for those patients? How do we pick up a potential tethered cord in a patient who hasn't reached the age of potty training yet? And then delayed presentation, which is often seen in this patient cohort, specifically due to the aforementioned issues. It can be hard to distinguish whether a patient's having an acute dysfunction from a baseline behavioral deficit. So this really clouds the picture in patients with Rubinstein-Tabi syndrome. And the biggest thing that I can tell you here is that parental observation is extremely critical in patients with RTS based on those signs and symptoms that we just discussed. And the reason for that is you know your child best. And parental observation often is really what can spearhead essentially asking the question, is there something going on? And then some screening considerations in these patients, whether that's with spinal ultrasound at birth or MRI brain and spine as part of their overall workup once this is diagnosed. So what is the workup for tethered spinal cord? We have some basic tests that we can do. The most basic of which is a spinal ultrasound, which is often done in infants, and it's best for young infants. What does an ultrasound look at? Well, it allows us to see essentially the cord itself, the nerves within the spinal canal, whether a spinal cord is at a normal level or not, whether those nerves and the spinal cord kind of move freely with the patient's breathing patterns or not. And the reason why this is good test for patients who are younger in infancy is because we can capture what we call good windows on the ultrasound because of the lack of tissue they have between their skin and the actual bony structures. As patients get older, or as children get older, this becomes increasingly hard, and the yield from an ultrasound becomes lower and lower. Currently, we know that the strength of evidence to support doing an ultrasound as a diagnostic test is low, but this is a non-sedated scan that can be done. It doesn't require very much. It is not invasive. It does not require, it can be done at the bedside in the hospital or as an outpatient. So there's not a ton that goes necessarily into, it's not as difficult to obtain as the next test that I'll talk about, which is an MRI. This is really the standard of care test for tethered spinal cord. And there are some additional things that I've noted here that can be added to a basic MRI scan of the spine to really appreciate some very nuanced things regarding tethered spinal cord. And I'll talk a little bit about these in some more detail. And so the MRI scan, again, does not involve any kind of radiation. However, most patients will require sedation to obtain very good images. And that has an added risk to it. But MRI does have high sensitivity and specificity for picking up the various findings that we look at for tethered spinal cord. A CNA study is essentially a specific sequence that can be done that allows us to see the motion of the cord and the motion of the nerves while the patient is breathing and with their cardiac cycle. And prone imaging is really something that we do for patients that we're concerned about tethered cord. The normal MRI is done what we call supine, which is on the patient's back. However, if we are considering tethered cord, many facilities will do prone imaging, which means after they've acquired all of the images as the patient has been flat, they then put the patient on their belly and then see if the cord has actually moved in the actual spinal canal. And this gives us some additional information as well. A myelogram is a more invasive test. This is a CT that's typically done, and there is an infusion of some contrast that occurs. So it is an invasive test where we do have to infuse that contrast into the spinal canal. And then evoked potentials, again, is a more invasive test to see if there might be some abnormalities in the muscles and nerves of the patient. So really going from top to bottom, level of invasiveness, level of ease in obtaining these imaging studies. So what are the findings that we're looking for? So in the most basic form, what I'd love for everyone to take away today on the imaging findings are the 3 L's. We're looking at the level, we're looking at the lesion, and we're looking at the locomotion or the movement. So the very basic forms of tethered cord can occur when a patient's spinal cord is too low. It's not sitting at the normal position. And so this is called a low-lying conus medullaris, and I'll show an image here shortly. Lesion. So what is it? What is causing the problem? Sometimes there can be fat that's infiltrated into the phylum, which is the ligament at the very bottom of the spinal cord that holds our spinal cords in place and allows us to have some motion and not too much motion, but not too little motion. There can also be a true, what we call phylum terminale lipoma, which is a true mass of fat that forms at the very base of the spinal cord that can cause the tethering. And then locomotion. So patients can have what we call a tight phylum terminale, which means that the actual ligament may be in the correct location, but it's not able to move as freely. And so keep in mind these 3 L's as we go through each of the next several slides. So the level, why does the level matter? Our normal spinal cord is supposed to be positioned in our lumbar spine. There are 5 big bones, L1, 2, 3, 4, 5, and the normal position is L1, 2. So if you can see this yellow arrow here, this is pointing to a spinal cord that ends at the very bottom of the L3 vertebral body. So we count from the bottom usually up. This is the sacrum. basically at the very bottom of the sacrum is our tailbone, and then we count from the bottom up, 5, 4, 3, 2, 1. Sorry, apologize. There are 5 big bones in the lumbar spine. So this is a low-lying conus or low-lying conus medullaris. The cord itself, the very bottom of the cord, which is called the conus, is low-lying. The graphic here on the side really illustrates what normal should look like versus what we see in the abnormal spine with a low-lying conus. So on the left of this picture here, you'll see the bones sort of, these are the spinous processes. These are the little bones that you can feel in the middle of your back. These are the anterior part or the front part of those bones that make up our spine. This is where we count the 5, 4, 3, 2, 1. Generally speaking, between L1 and L2 is where you're going to find your conus or the very end. And this is kind of where the spinal cord tapers down. And then you see this spaghetti looking like structure here that's called the phylum. The phylum is a ligament. It's supposed to have some laxity in it, not too much, like I said, but not too little. And so there should be some motion that allows the spinal cord and the nerve endings to float freely within our spinal canal, which is full of spinal fluid. On the right side of the screen, you see where this is more taut, and this is really a straight line, and it has really pulled the actual spinal cord down below the normal level. And so this is one of the things that one may read on an MRI finding, and we see this incidentally in a lot of patients, but in a patient with RTS, there are some special considerations. The lesion. So there can be other things. It may not just be a simple phylum that we see that's on some stretch or a low-lying spinal cord. We may see what we call a fat-infiltrated phylum or a fatty phylum, otherwise also known as a fibrolipoma of the phylum terminalis. So all of these terms really simply are interchangeable and really mean that this phylum or this ligament is thickened and it is full of fat or is infiltrated with fat. Now, the normal thickness of the phylum on an MRI scan is less than 2 millimeters. And this thickness does not change as the child ages. So you really are born with a certain thickness of the phylum, and that should not change. If a patient has a fat within the phylum or fatty infiltrated phylum, that can change, because just like fat deposits in other parts of your body, fat can deposit within the phylum as well. And so we can see a fatty phylum gets thicker or become a problem in a patient that has that to begin with. And so what does the fat look like? It is this, so similar to that last picture that we saw, here we're looking at the lumbar spine, the big blocks again, 5, 4, 3, 2, 1. This conus actually ends right at about the back of the body of L1. I apologize, this arrow should be mobilized a little bit, but this brightness that you see, this brightness is actually fat. You can see the fat that's bright underneath the skin back here. And this is what fat looks like inside of the spinal canal as well. Again, another graphic on the right part here that really just shows you what the normal spinal canal and the normal conus and the normal phylum should look like. And all the way to the right here, what a fatty tissue phylum looks like. And it is thicker. There's fat in there, fat sticky. And so it can cause tethering and cause things to get stuck within the actual spinal canal. And then the last thing that we want to talk about on the imaging is motion. So does the phylum, or the conus specifically, does the conus and do the nerve endings in the spinal canal move normally? So, or does a patient have what we call a tight phylum terminale? So this simply is due to restriction of movement of the conus within the spinal canal. Based on looking at many normal MRIs in children who don't have any kind of syndrome or any kind of findings or associations, we know that the average conus tip, or that very tip where it tapers to the end, should travel a certain distance. So The average is about 3 to 5 millimeters within the spinal canal, and the typical distance traveled inside the canal is about 25%. So our radiologists are very savvy when we do this prone imaging, or when we put patients on their back and then put them on their belly and then compare the two, to see how much motion is there. Is it restricted? And in general, the benchmark that most radiologists will use to call motion normal or abnormal is really going to be this less than 10% distance traveled in the spinal canal. So does that conus stay back where it was initially found or not within that specific range? So what else do we care about? The imaging doesn't tell the whole story. Many times patients present with urinary dysfunction. And so how do we test that? We do this in essentially along with our, in consultation with our urology colleagues. And often they're ordering they can order a single test, multiple tests, or a slew of tests depending on the certain situation. And so listed here, you'll see more or less a comprehensive list, but not limited to this, but the more common tests that are ordered to study urologic function, or what we call urodynamic function of the bladder itself. The simplest study, again, is an ultrasound. It's an ultrasound of the kidneys. Many children with RTS can have abnormalities within their renal system or in their kidneys. And so the most basic test to start with is the very first part of that urologic system, which is the kidneys. And specifically to look for if there are any abnormalities that can be found. The next test listed here is called uroflowmetry, and that's really just a measurement of the flow rate. So how much is in your bladder and how fast does it come out? The post-void residual measurement is often done using an ultrasound. Sometimes it can be done using a Foley catheter. But simply it measures how much is left in your bladder after you actually urinate. And there are normal numbers based on patient's age and bladder capacity. The cystometric test, or cystourethrogram, is a very big word, but essentially is a more invasive test that involves using Foley catheters, and typically 2 Foley catheters. And what does this test measure? It measures how much urine your bladder can hold. It measures how much pressure can build up inside your bladder as it starts storing the urine. It also measures how full your bladder is when you start feeling the urge to urinate. So the reason for the 2 catheters is that one catheter is what you use to void, and the other catheter actually has a little sensor in it that measures, and that's how it can measure when you're sense when your bladder is ready to empty. There's a leak point pressure measurement, again, measures your actual sphincter function, and at what point does your sphincter start to open and need to empty. The pressure flow study measures how much pressure your bladder needs to urinate and how quickly urine flows at that pressure. The EMG, or electromyography, is where, again, this is more invasive now. We're talking very small needles that go into the actual sphincters to test that have special sensors, and that measures the electrical activity of the muscles and the nerves in and around the bladder and the sphincters. And these are often placed near the urethra. They can be placed near the rectum or in a catheter as well. And that this activity is then recorded on a machine, and we look at the patterns of the impulses to show whether the messages that are sent to the bladder and the pelvic floor muscles are actually coordinating properly. But again, this is a little bit more of an advanced test, and certainly done in patients where we perhaps don't have enough evidence from other testing, and we really need to measure this in order to determine whether or not there's abnormal bladder function. And then finally, the video urodynamic study, which are tests that use x-rays or ultrasound, where pictures and videos are taken of your bladder while it fills and empties. Again, this requires a Foley catheter, and usually the bladder is filled basically to its capacity with contrast or dye to obtain those imaging. find those imaging studies. So sort of just in the order of invasiveness here, the most uncomfortable truly is often the EMG or the electromyography is done with some form of sedation. And so many patients, and so are the video urodynamic studies, but many patients do not tolerate those tests very well, depending on, of course, their age and their baseline disability. So what do we do? What do we do in surgery? Once we determine a patient actually has a tethered cord and we've given them that diagnosis of a tethered spinal cord, the surgery has some very standard steps. And I'll show you some images here in a second, but the simple steps that we go through in the surgery are the patient is positioned. They're positioned usually on their abdomen in what we call the prone position so that we have access to their back. Oftentimes, we will get an X-ray of the spine to make sure that we're happy with the exact level that we're going to approach for the surgery. Once we mark the actual incision and have identified the location, we then make a vertical incision in the lumbar or the sacral area based on, again, determining where the level is that we're going to go for. We move forward with essentially the dissection, which involves then cutting into the skin, the fat tissue. We separate the muscles at the above the actual bones, and then we do something called a lumbar laminectomy or a laminotomy. This simply, these are just terms that simply are able to let us know whether there was only a very little amount of bone that was removed or a full amount of bone at the actual level that was removed. So it really just the extent of the bony exposure. Then we do what we call a dural opening. The dura is the covering around the spinal canal. And then we open that covering. We then identify the actual phylum. As soon as we open that dura, then there's spinal fluid that leaks out. And most often we use a microscope. I would say probably the vast majority of pediatric neurosurgeons will use a microscope to do the tethered cord surgery. So that we can just really at high magnification appreciate the anatomy. We identify the phylum or the pathologic issue, and then we move forward with the detethering procedure, and I'll show you some images of that here in a second. We then close the dura once we're done with the detethering procedure and sew it shut, and then do a watertight closure of the different layers that we gradually had opened earlier. So here's some of the surgical observations. So what is our positioning? It is prone. The patient is on their belly. Their chest is supported. Their hips are supported. Patients are intubated, fully intubated under general anesthesia, and our anesthesiologists will do that when the patient is on their back, and then we all very carefully in tandem will then flip the patient together, and then we move forward with localizing the area or the level that we want to work at. There's a graphic here just below that positioning that really just shows just a quick cartoon, if you will, of the actual incision. We make the incision where we've marked it. We then separate the tissue and then go down to the actual spine. Once we've removed just a little bit of bone, more often than not, we are able to actually stay in between two bones and work within the actual interspinous ligaments, and we have to remove very little bone within the spine. And we are able to find that we are able to get the exposure that we need of the dura itself. On the right here, you'll see the very top photograph is actually the dura has been opened. So the two edges are held apart here with some suture. And this is what we see in surgery. What you can see up top here, these are actually the nerve roots. These are all the nerve roots that go to the patient's legs and allow them to feel and move their legs and their bladder and bowel control as well. So we have a right side, we have a left side, and then all of the sphincter or all of the sacral nerves or the nerves that go to our bladder and our bowel are actually, they center in the middle. And right in that center as well, we see what we call the phylum. So you can appreciate this very thick structure here that looks different. Nerve roots often look more yellow or can look even more tan compared to the actual phylum. The phylum is more shiny and it often looks more white, and it will have a yellow tinge to it if there is quite a bit of fat in it. And that's how we identify it anatomically. The fatty phylum is then isolated, and often we will use spinal monitoring, which I'll explain in a second here. And those spinal monitoring allows us to really basically stimulate the actual nerves, and that's how we know the nerves are the nerves and where they're going. And we stimulate the phylum to make sure that it doesn't have any kind of stimulation to any of the muscles in the legs or to the sphincters. And that's how we know that it is it should not make anything go off. It should not stimulate anything because it is a ligamentous structure and not a nervous structure. And that's how we isolate it, and that's how we also keep the patient safe, and we don't cut anything that's important or that is functional. And we detether then the phylum. And as you can see here, there's a very clear demarcation here. There's a right side, there's a left side, or the top and the bottom. And then this is the bottom edge of this phylum that's been cut. This is the top edge of the phylum that's been cut. More often than not, what we will find is when we cut that phylum, the two ends spring away because there is so much tension on that cord. There we see a brisk recoil into the spinal canal above where we're working and then also below where we're working. So what are the risks? I've explained this surgery to you, but every surgery carries risk, right? And I really focused on these 5 major categories of risks associated with tethered cord surgery. With any surgery, you're going to have a risk of bleeding and infection. But specifically for tethered cord surgery, there is a risk of cerebrospinal fluid leak. There's always a risk because we're working around the nerves and the spinal cord of neurologic injury. And that can present itself as weakness, as numbness, as tingling, as pain, as further bladder dysfunction or as further bowel dysfunction. Or the possibility of retethering, which might require additional future procedures. So how do we mitigate these risks? Specifically for bleeding, along with our anesthesia colleagues and hematology colleagues, if we find any abnormalities, we can address some of these things early on. And so prior to surgery, even being scheduled often, we are checking weeks prior, we're checking the patient's hemoglobin and hematocrit, we're checking their coagulation factors or their bleeding factors. How quickly can they stop bleeding? So how quickly can they clot, essentially? And we check their platelet count because the platelet count is important for whether or not a patient can form a clot and stop bleeding. We check a type and screen, which helps us to have blood available if we feel a patient is at higher risk for bleeding. And we stop medications that we know are known to put patients at risk for bleeding within our surgical procedures. Specifically, those include the NSAIDs, so aspirin, ibuprofen, Advil, Aleve. Any one of those medications are considered NSAIDs, and they do have and carry some bleeding risk because they do cause platelet dysfunction, and other medications that may have bleeding risk depending on the patient. Thankfully, tethered cord surgery is a very, very low bleeding risk surgery. And so we check all of these things as a safety measure, but we don't often find significant bleeding in patients who have tethered cord surgery unless they have some kind of underlying risk related to bleeding. Infection, this is a big one. How do we ensure that a patient doesn't get infected, or we don't put them at higher risk for infection with this procedure? So, as Dr. Black alluded to, we always want to ensure a patient's not ill prior to surgery. That puts them at higher risk for both anesthesia, but also for the surgical component of the procedure. We, in our practice, and this is not necessarily done globally, but we do check something called a staph screen or a preoperative staph screen, and this essentially checks the patient's skin to see if they have bacteria that we need to specifically target or address. The most common bacteria that cause skin-related infections are staph or Staph aureus or Staph epidermidis, and some of them can be resistant, especially in complex patients who have had prior procedures, who have had prior hospitalizations. So if there's a patient that has resistance to some of the normal, typical antibiotics that we would use, we would want to know that beforehand so we don't use the wrong medication or the wrong antibiotic for that patient. and it helps us tailor what we're doing in terms of our preoperative and our postoperative antibiotic protocol to the patient. We have very standard preoperative bathing instructions that we give to every patient, and we provide the actual soaps and the cleansers to the patients to bathe prior to surgery. And then we have a very standard perioperative antibiotic protocol, which includes giving a dose of antibiotic prior to making incision, so within 25 minutes of incision, but also every 4 to 6 hours during surgery if there is a surgery that lasts longer. Now, thankfully, again, simple tethered cord surgery. So tethered cord surgery is also on a spectrum, but the most simplest form of tethered cord surgery often will take somewhere between 2 and 2.5 hours, depending on the surgeon. We also administer 24 hours of antibiotics postoperatively to protect the patient within that vulnerable time. And in surgery, we use antibiotic irrigation at a very specific level of the soft tissue to ensure that we prevent infection in that way. And that's really been our protocol, no matter who the surgeon and no matter what the type of tethered cord surgery we're doing. We also do very careful and meticulous skin prep during the surgery. So this, again, and we pick the skin prep, again, based on the patient's allergies or their ability to tolerate a specific type of skin prep. We avoid contamination of the sterile field. This goes for any and all surgeries, but certainly for neurological surgeries. And then we have a very standard postoperative wound care and daily washing regimen that we both adhere to in the hospital, but also educate families prior to leaving the hospital about prior to their outpatient wound check. Cerebrospinal fluid leak. So this is the big one. This is probably the most specific because we are opening the spinal canal and we are letting that spinal fluid out intentionally as part of the procedure. The things that we can do best at the time of surgery are to ensure a very tight closure of that dura. We do that with a very specific type of suture. Again, the type of suture may be dependent on the surgeon, but there are certain sutures that are known to allow us to do a very good dura closure. We ensure a watertight closure of the fascial layer, which is really the strength layer in the back, and that's just above the muscle layer. And we do enforce what we call a flat time post-surgery. Now, again, this will vary depending on the institution, depending on where you are in the world. Many neurosurgeons will not keep patients flat at all. Many neurosurgeons will keep patients flat for 1 day. Some will keep them flat for 2 days. Some will keep them flat for 3 days. That really just varies by provider. What we know is that there isn't a huge difference between the time that patients are kept flat. However, keeping them flat, the idea behind keeping them flat is really to allow that layer to heal and not have significant pressure on it related to straining maneuvers or movement. And so, again, the flat time at our institution can vary between 48 and 72 hours. Now, trying to keep a patient who is a year old or 2 years old who is on the move flat after having had a painful procedure can be very tricky. And so this is where we also look to our ICU colleagues and our anesthesia colleagues to really provide us the best solution in how we can keep these patients calm and how we can keep their pain under control and keep them comfortable and recumbent for the period of time that we're interested in. And as I said, it's really critical to avoid early sort of what we call the Valsalva or straining maneuvers. So patients are put on a bowel regimen often quite early because we don't want them to get constipated and strain and have difficulty having a bowel movement, since that is the biggest culprit often of having even a very small CSF leak. And really no significant strenuous activity. Although many times, when you have a patient that, as I said, is in that sort of young toddler age group, it's very hard to keep them still or keep them from doing what they want to do. But what we don't want is to put them in any added strenuous activities. So we will typically hold back doing any kind of excessive or any kind of aggressive physical therapy for 2 weeks until we've noted that their wound has healed appropriately and that the trajectory is positive related to healing. And from a neurologic injury perspectethe, of course, we're working in the nervous system, around the spinal cord, around the nerves. And so the biggest thing that we do during surgery is something called spinal neuromonitoring. This is where very small monitoring needles that have little sensors in them. They're very thin. They're akin to acupuncture needles, if you will. They go into the patient's legs and their sphincters. We also have a special Foley catheter that we utilize to test the patient's bladder reflexes during surgery. This is how we do triggered EMG, where we can touch a nerve and we can make a muscle move that's associated with that nerve. And we can know whether or not the structure that we are looking at or we are stimulating is actually functional or non-functional. There are other different types of potentials that we can also measure. We can measure the motor function going all the way from the brain down to the limbs, or the sensory function. Often we don't do this with tethered cord surgery. Mostly we're really interested in that triggered EMG and those bladder reflexes. And again, this is going to vary. Whether or not someone uses spinal monitoring will vary depending on where you are in the world. We also do very careful study of anatomy. It really matters. Preparation for the surgery really matters, and how successful you are in really obtaining the appropriate exposure and essentially seeing the spinal anatomy. We also want to make sure that the spinal cord is well perfused. Generally speaking, we're not actually seeing the physical spinal cord in tethered cord surgery. But if there is a mass or something that is intimately involved with the spinal cord or the base of the spinal cord, we want to make sure that the patient's blood pressure is adequate and that that spinal cord is being what we call perfused, or getting enough blood flow. And then we also administer steroids for certain patients during and after surgery to reduce any inflammation that could have been introduced by just doing the surgery itself. And lastly, I want to talk about the possibility of retethering. So this tethering thing happened. We took care of it, but can it happen again? It absolutely can. And so what we can do, again, during surgery, we ensure a clean dissection, which means trying to keep any kind of bleeding out of the spinal canal, really being meticulous with our irrigation, cleaning out that space, and ensuring that we haven't left any kind of little particles behind from just having been there and doing the surgery that could then cause parts of the spinal cord or little roots to get stuck to our closure. And the steroids also help with reducing the inflammation. One of the most common causes for retethering is going to be something called arachnoiditis, or basically inflammation of the very fine layer of tissue that is everywhere really within the spinal canal underneath that dura. So what are our post-surgical considerations? So we haven't stopped yet. We've done the surgery and then we are in the recovery period. So pain control is critical, and this is where our anesthesia colleagues really help us very much in terms of finding the appropriate pain regimen and the tailored pain regimen to the patient. As you already heard, there are special considerations for patients with Rubinstein-Taybi syndrome. The flat time, we talked about a little bit as well. Bowel regimen is critical. Physical activity, often limited in the very early period after surgery, but we always have our physical therapists evaluate the patient, evaluate their function, and provide any additional recommendations prior to discharge from the hospital. And urologic follow-up is important. So sometimes some patients receive a urologic consultation within the hospital if one of their presenting symptoms was related to their bladder, if the urologist has determined the need for that. Oftentimes what we find is that we want the patient to recover. Nerves can take weeks to months to recover from having some kind of intervention done to them. And so the urologic follow-up often is 6 to 12 weeks after surgery, where any one of those studies that might have been abnormal prior to surgery can be repeated to see if the surgery itself made a difference in that short interval time frame after surgery. And then retethering. So it can happen. The biggest culprit, as I said, is truly just related to being in that space altogether, and it's called arachnoiditis. That can happen related to whether the CSF itself is predisposed to material or anything that you may have left behind, or if a patient gets an infection. Infection can really cause a significant amount of inflammation. And so again, why it's so important to make sure that all of our infection protocols are in place. Approximately 7 to 8% of patients can have retethering, even with something we consider a simple tethered cord release. So it is a real possibility. So what are the takeaway points? That was a lot of information, a lot of detail about tethered cord syndrome, about the surgery itself. But the things that I really would love for this group to take away are, what is the incidence of tethered spinal cord? Is this common? Is this uncommon? Rubinstein-Davy syndrome is already a rare entity as it is. And about 5% of patients can present with tethered spinal cord. So it is enough of a percentage that we should consider keeping those signs and symptoms really top of mind, as well as considering screening, whether that's with ultrasound or with MRIs earlier in the patient's course. Parental observations are critical. Oftentimes, the changes or the symptoms that we're seeing are really subtle, and they can happen over a period of time. And this may not be something that's simply captured in one moment or one instance, and really taking a multidisciplinary approach. So if a patient presents with a foot deformity, or if a patient presents with scoliosis or a spine curvature, really working with our orthopedic colleagues to educate them about in a patient with RTS, this could also have the patient could also have an underlying tethered cord related to some of these other findings, or some of these other findings may actually be as a result of a tethered cord. Early screening is helpful. MRI is really the gold standard test. It's the most helpful for a surgeon. Intervention for symptomatic patients is recommended. So if a patient has symptoms that correlate with the imaging that really tell the picture or tell the story of tethered cord syndrome, intervention is recommended for these patients in patients with RTS. However, if the patient has no symptoms, but incidentally on screening tests was found to have something abnormal, but a patient does not have any of the red flag signs or symptoms, observation is recommended. Very close observation is recommended, because those symptoms could potentially come up as the patient gets older and as the patient ages. And one thing I didn't really bring up was that we often do quite close surveillance on patients, even when they don't have symptoms, because we know that tethered cord syndrome can occur, particularly during those pockets of time or within those critical years where patients are going through growth spurts. And that's really when they can come into play as well, if it's not picked up early on in life. Surgical recommendations should always consider the anesthetic risks. This is why we all work hand in hand with our anesthesia partners. Surgical intervention is considered what we call low risk and low morbidity from a neurosurgical perspective, which means it's a very safe procedure and it can be done with few complications and nearly zero mortalities, again, related to the procedure itself. And the goal is really for preservation of function and prevention of worsening. And then individual protocols for post-surgical care may vary, but typically what the biggest focus is really on the improvement of the deficit that the patient came in with prior to surgery, whatever that is, the sign, the symptom. Pain is almost always the first thing that is improved after a tethered cord surgery. And more than 90% of patients will have improvement in their pain if it's related to a tethered cord. Prevention of deficit in the future that we may anticipate based on the patient's baseline function, and then close follow-up is very, very important, because again, this is something that we follow longitudinally, and it's not something where, we potentially see a patient once and we say, okay, I don't think you have tethered cord syndrome. Come back and see me if you need. And that is it for me. I will stop sharing here. I see there's a bunch of comments or questions that have come into the chat.
Wow, that was a lot. There should be some award there for the amount of information that was put into this room during this time. I want to respect time. I put in the chat while you were speaking that we would go ahead and move and continue with questions if folks wanted to stay, but if they didn't, it's still being recorded and they can get the recording and hear the answers later, just understanding families' commitments, et cetera, et cetera. So I'm going to kind of summarize some of the questions a little bit. Some of them are pretty specific. Many of them in some capacity have to do with the idea of we've had some sort of assessment of whether or not to rule out tethered cord, right? And it came up, no tethered cord or and such things. How often and should we, if we begin to see symptoms, et cetera, possibly ask to have it reassessed or looked at again? And what's your recommendation there? And then I'll go on to a couple more, but go ahead. Just broadly, how frequently, if they've been told it doesn't exist or it's not there, but they're still kind of questioning it with other things they're seeing.
Yeah, so generally my practice is once a year. So yearly is what I would say. Most of us in our division follow patients, even if there is an incidental finding, but a patient's not symptomatic. We may not necessarily re-image the patient every year, but we do want to do a clinical assessment and do our own sort of history taking to determine whether or not, there are any red flags or signs. So yearly.
Okay.
And that interval can be much shorter depending on what's going on with the patient too.
I just wanted to jump in really quickly, if possible, and just express gratitude for Dr. Black for answering all these questions in the chat, and just wanted to
Yes.
respect your time if you would like to go. Did not want to see you leave without saying thank you.
No,
We
thank
appreciate you
you.
so much.
I'm gonna keep listening. Thank you.
Okay, cool. Awesome. Thank you.
One in particular was talking about her son has severe scoliosis and they evaluated him for a tethered cord, but they said they didn't see it. But they also had not seen many patients with RTS. And she was wondering if he does have a tethered cord and they potentially missed it, if it gets adjusted, could that impact the scoliosis and how?
Yeah, so, it really, tethered cord is often, those findings that I was describing are often picked up by a radiologist. And so if a patient has scoliosis, and I would say in general, this is not just specific to our RTS patients, but we see about 10% of patients who have scoliosis that can have an underlying tethered spinal cord. And there is enough evidence to show that when those two things coexist, that detethering the cord can be protective for progression of the scoliosis. And so often we work with our orthopedic colleagues to see the patients, to assess them whether or not they need something, and such as a detethering, simply to prevent progression of their scoliosis, depending on how severe it is. And if a patient has scoliosis that requires intervention, so that requires surgery, and as part of the workup, a low-lying conus or a fatty phylum has been picked up, again, incidentally related to that scoliosis, we almost always will recommend detethering the patient at the time of the scoliosis surgery.
Okay. And there were a couple that were brought up, and I'm thinking I'm hearing in your voice to just continue that going back and getting reassessed. But again, very early at birth, low-lying conus, but no fatty tissue. And the question was there a likelihood? And what I'm hearing from you is keep going back and asking the question potentially, or is there more to it than that?
Yeah, there can be, and especially with those growth spurts, right? So if a patient has a low-lying conus, again, so a normal conus is a 1-2. Many patients can have what we call a borderline low-lying conus or a borderline conus, which is really just at that inferior edge of L2. A true low-lying conus is going to be at L3 or below. That's usually the one that's where we're going to want to see the patient every single time. When a patient has a borderline conus, plus or minus, again, depends on whether or not they're having signs or symptoms, but they certainly can potentially, develop tethered cord syndrome as they get older.
We have two questions. Oh, sorry. Two questions that are pretty specific, and I don't want to get into you diagnosing tethered cord or not, obviously, but
sure. One
is a 4-year-old who suddenly prefers to crawl, especially early in the morning. And the other one is an adult male who is beginning toe walking, but only on one side. And I'm gonna guess, but go ahead if you want to respond to both of those. I don't want those to.
Yeah, so I mean, I think both of those things, certainly there is a possibility. But what I would say is that, again, in patients with Rubinstein-Tavy syndrome, there are just so many different reasons for why a patient, may have certain behavioral regressions, or, may have sort of a tendency to do one thing versus another. And that it truly depends on what the patient is like at baseline. And I think that with a 4-year-old who is now regressed to potentially crawling and not really wanting to walk, again, the questions must be asked, is this something that's a situational thing that's happening, or is it something that is really persistent? Can the child actually, have they truly regressed in their walking, and prefer to crawl all the time, or is it really just related to a certain time of day or a certain activity? As far as adults, there are a very small subset of patients that we can diagnose tethered cord in, but it's just been missed. Or a patient just doesn't have any symptoms until they become older. And so we definitely do have a cohort of patients where we have diagnosed tethered cord as an adult. It's not as common, certainly, but since they have done sort of their full potential of growth, but it is something to consider.
You had said MRI is the gold standard. If no imaging has been done, or if they look more at an ultrasound, your thoughts on those two?
Yeah, so ultrasounds have really good what we call sensitivity, which means they can rule out a lot of things, but the specificity for an ultrasound is quite low. And so an ultrasound can show something that looks low lying, but more often than not, when we get an MRI to try and confirm those findings, the MRI is completely normal. So it essentially, can be a confounding sort of study. So it's good for like screening, right? So, but it's not great for actually diagnosing the issues. So many patients have abnormal ultrasounds that can have totally normal MRIs. And the MRI just gives us so much more granularity in what the patient's anatomy is. So that is why we consider it more of a gold standard test, because there's more evidence that an MRI picks this up.
Okay. What I'd like to ask from you, if at all possible, Dr. Patel, would be to share these questions with you, because I kind of generalized them, but I'm looking at time and we're almost 15 minutes over. So if I could send those to you, and then I can make them available along with the recording so folks can see them. And I'll save the chat with Dr. Black's just such attention to detail. Thank you so much. You guys have been absolutely fabulous. This is one of my favorite spaces to be, but you guys have raised the bar. I'm just so appreciative of the opportunity that you gave to our families by taking your time out of your evening. I cannot say thank you enough. So on that, I will go ahead and wrap up. But folks, if your question wasn't asked directly, I will send them to her. We have I think over 13 questions. So, and I know that Dr. Black's fingers probably hurt from typing too. So, so thank you all so very much. We really appreciate all of you. I'm going to give the floor really quickly back to Lauren so she can tell you what to expect coming up.
Yeah. We are celebrating Rare Disease Day on Friday, February 28th. And I just wanted to point you guys to the rarediseaseday.org website, where they have stories, events, and resources to explore to spread awareness about Rare Disease Day at the end of the month. And then our next speaker series will be on Tuesday, March 4th. Dr. Susan Wiley will be with us talking about transition to adulthood. So we will be sending out information about that very, very soon, as well as some follow-up with this meeting and this event. And last but not least, we just wanted to share our contact information if you have questions. And then this survey, we really, really would appreciate you taking a moment to take. I can also send this out with our follow-up. We are planning our speaker series for September, starting, at the end of the year. So we would love to hear some feedback about what you enjoyed about this series and what kind of topics you're looking forward to learning about.
And keep in mind that our survey results are always shared with our funders, and it's really important to funding to be able to keep events going. So please take the time. I know surveys can be tedious, and by the time you leave an hour and a half of this, you're tired. But we'll send it again in the email. So please take a minute and give us your thoughts and your feedback on that. Again, Dr. Black and Dr. Patel, fabulous. Thank you so much. And Dr. Riddle, thank you for your time. And we will see you all at the next event. Thank you.
Thanks for having us.
Oh, you guys were fabulous. Have a
Thank you
great
so
night.
much.
Hello,
Tell me who to send letters to tell them how amazing you were. Thank you.
hi, doctors. Just one more question. So to confirm, you're gonna send us the link for the evaluation so we can check marks. You guys can send us the link for the recordings, right?
Yes, will do.
Yes, the link to the recording. The evaluation link is in the chat, and and there'll be a question if you need the recording. So that's part of your evaluation part, but there's a link in the chat, and we'll also email that.
Okay, great. So all the
Mhm.
recording, because I was late for this meeting, so my wife was mad at me. So if you guys can send us the link of the
We'll get you out of the
recording,
doghouse. No worry.
okay, great, thanks.
No problem.
So you got us an email address, I guess. Okay, thank you.
We should have it from when you registered. Yep.
Yeah, okay, great, thanks.
All right. Thank you.
Okay.
Lauren, remind me and I'll check with you on him. We'll make sure we have everything to get it to him.
Definitely.
I don't want him to get in trouble.
Thanks a lot.
Thank you. Have a great night.